Thank you all for attending this webinar, weekly KSA webinar. My name is David Waruingi. I'm an anesthesiologist working in Kenyatta University Teaching and Referral Hospital. And I'm glad to be here with panelists who I've worked with before in different capacities during my career. So first, I want to appreciate all of you for tuning in and taking time out of your busy schedules to come. I also want to appreciate the panelists for also making time to present on this interesting topic. I also want to appreciate our sponsors today, Sanofi, for giving us this platform, and KSA and the officials for organizing such a wonderful talk. So just a few housekeeping rules. If you have any questions, so all the panelists will talk. Let's keep the conversation going on in the chat. They'll respond to your questions as and when. And at the end of when the final panelist speaks, I'll take all the questions and I'll direct them to the respective panelists. So our main speaker today first speaker is Dr. Umair Ansari. He's a consultant anesthesiologist in the University Hospitals of Coventry and Warwickshire. He graduated from the University of Southampton, and he completed his anesthetic training in Nottingham. He then did an advanced year as a simulation fellow and completed a master's in patient safety and quality improvement at the University of Nottingham. His main interests are management of the difficult airway, patient safety, and human factors. So he's quite best placed to speak about simulation, and he'll introduce it from base up and explain everything. And I hope we can interact. So welcome, Umair.
Thank you so much, David. Thank you to everyone who has logged in. As David said, my name is Umair, and I have about 20 minutes or so to share some thoughts about simulation and patient safety. And as David has already alluded to, those are two things I'm quite passionate about, having done a master's in it. 20 minutes will never do simulation or patient safety any justice, but I'm just trying to give you some sort of flavor of what you can be doing in the hospitals that you're in, and what simulation can offer in terms of improving patient safety. So without further ado, I think we should get started. And we start, some would say, at the beginning of the modern era. There is a paper which I would recommend all of you to go and look at. It was published by the United States government agencies, and it was called "To Err is Human." And this paper was published in 1999. And it was a seminal paper looking at the sort of damage we can do as clinicians, and how much damage we do to patients. We all consider ourselves as safe and good clinicians, I hope, and I'm sure we all are, in our minds at least. But you cannot deny that there is a number of patients who do not receive the best possible care that they can. And most of the time that is unknowingly, but some of the time that can be knowingly. And this paper looked at the number of patients in the United States who had suffered avoidable harm in the hands of clinicians like you and me. And what they found was that in 1 year, between 75,000 and 300,000 patients estimated would have come to avoidable harm through what we do in our daily lives. And so this was the point at which the world started to think, how unsafe are we as clinicians? And this is a graph taken from a paper that was published recently. And as you can see here, there is a number of industries that we are compared against in healthcare. And we call these industries high reliability organizations. And these are organizations that are given the task of doing things such as aviation, such as producing electricity using nuclear power, and they're expected to perform safely. Now, as you can see from this graph, it's very clear that healthcare sits somewhat outside of the safety of other organizations. And I'm continuously asked when I present this slide, why it is that healthcare should be compared to high reliability organizations. After all, we look after patients who are unique and sometimes very difficult to understand, investigate, and treat, which is not something that you would expect in a nuclear power station. But actually, when you start comparing the systems and processes of both healthcare and what they might do in a nuclear power station, it becomes clear that we have more similarities than differences. And that's something I want to concentrate on today, because for me, simulation is about systems and processes. And we'll talk a little bit more about this. But I want to explain to you in this very short period of time, why it is that healthcare, especially in recent times, has become more patient safety has become more difficult for us. And that is related to complexity. So we know from just how much we have to learn at medical school now compared to 50 years ago, that the complexity of medicine has increased significantly. And this is because we know more, and therefore we need to understand more, and therefore we need to retain more, and therefore we need to perform using more information. And that leads to what we call cognitive overload. And you can see from this quote from Professor Atul Gawande from Harvard University in his book, The Checklist Manifesto, that knowledge has both saved us and burdened us. And that's so true in what we do on a daily basis. And I'm sure you're all familiar with this. So aside from everything else, I highly recommend this book. If you can get hold of it, please do read it. It's fantastic. And especially if you use the World Health Organization checklist, which I'm sure most of you do, I would highly recommend reading this book. It puts into perspective what we should try and strive to be able to do with the checklist. I'm going to move the talk on a little bit to certain aspects of simulation that I think are useful incidents and useful sort of tasks and tools that I might be able to offer you to help you either be able to use simulation as a tool to help you make your workplace safer. The first thing I want to mention, and some of you might be familiar with this incident, is the case of Elaine Bromley from 2005. If you're not familiar with it, unfortunately, we don't have much time today, but I would highly recommend that you Google just a routine operation. And there is a whole video of this produced by Elaine's husband, who is a pilot, and it's called Just a Routine Operation. But very briefly, in 2005, in the UK, a young female was induced with anesthesia for some ENT surgery. And unfortunately, the anaesthetist who was in charge of her care that day became somewhat task fixated at intubating her. And despite a number of things that could have saved her potentially, there was this task fixation that we had to intubate her. And despite there being a number of technically skilled personnel on the floor, unfortunately, she died as a result, a direct result of the incident that took place in the anesthetic room that day. There are many learning points from a human factors point of view, but one learning point for me for this particular incident is that about culture, that about the fact that in your organization, when you work together as a team, and I'm not just talking about your direct team, your anesthetic assistant, your scrub team, I'm talking about your organization, there needs to be a culture of safety. Otherwise, progressing with patient safety is very difficult. And I will talk a little bit more about this, but just to bring it home and to continue the comparison between different organizations and anesthesia, as David knows, I'm quite a big fan of aviation, and even more so looking at aviation investigations into crashes and what we can learn in healthcare from these. Now, of course, I'm sure all of you are quite familiar with Flight 302, which unfortunately and tragically killed so many people on the 10th of March, 2019. It was, of course, a Boeing 737 MAX, which has become world famous as a consequence of the two tragic incidents that it was involved in. The reason I bring this up is because the pilots on that day did nothing wrong. The only thing that they unfortunately were a victim of was not being trained and not having the simulated practice to be able to operate the machinery that they were. And again, going back to the last slide with regards to culture, this was ingrained from a culture of making shortcuts from Boeing, cutting costs, and not retraining and not allowing the world-class facilities that I'm told that the Ethiopian Airlines have to simulate these sort of incidents. And so this can be the result of not using simulation. And it's an important point that if you don't practice what you are doing on a daily basis in a safe environment, you can end up with results like these, and they may not be an individual's fault as to why that happened. It may be a cultural fault from the organization, and we can all learn from that. And if you take nothing away from today's lecture, may I suggest that all of us should strive to maintain what we call a just culture. And these points are so important when working in an organization. If you're the clinical director of your department, if you have a managerial role in your department, and as an individual that works in a department, it's really important to stick to these practices, and they can really help in shaping the culture of a department and making systems and processes better, safer, and providing a better state of healthcare for your patients. Now, of course, the title of the talk was using simulation as a tool to help improve patient safety. So let's move on to simulation. Now, one definition of simulation is the imitation of the operation of a real-world process or system over time. And you can see why I've been stressing those words. For me, simulation is about the non-technical skills. The technical skills, such as being able to intubate somebody, being able to do a fiber optic intubation on somebody, can and potentially are better learned in a real-world environment. What can't be so easily rehearsed and perfected is those systems, those checklists, those logistics, the way in which we interact with each other, the way in which we talk to each other, the way in which we behave in a stressful situation. But fortunately, all of those things can be practiced in a safe environment in simulation. And this is what some simulation suites looks like. This is one in Coventry University, close to where we work. As you can see, it's fairly realistic. But the reason for showing you this slide is not that you need these sort of facilities to practice. I mean, they're very nice, but you don't need such high fidelity equipment and areas to practice those processes and systems. And I'll tell you a little story about that in the upcoming slides. I just want to direct your attention to a program called Team Steps, which is a program that I've been engaged in for a while. You can, again, Google Team Steps. It is an American program. It is free to enroll, and you can learn about the facets that make up good team working and how to use simulation to bring out the best in people. Just want to touch on a few things related to simulation and things that we can get out of simulation, really. And I keep on saying, and I keep on going back to aviation, but if you look at aviation, which is probably a good 30 or 40 years ahead of us in terms of safety, you notice that aviation incidents involve about 70% of them involve human error. And 88% of those 70% are a loss of situational awareness. So what does that tell us? It tells us that situational awareness is really important. And actually, if you look at anesthetics, there have been a number of cases here in the UK where situational awareness has been blamed, or loss of situational awareness has been blamed for the outcome of the patients. And again, I'll direct your attention to NAP4, which is our National Audit Project number 4, It's published in the UK. Again, you can Google it. It's free to look at. And there's so many learning points about human factors, about practicing non-technical skills and being able to perform better in a real world environment because of that. Just very quickly talking about situational awareness, all of these things, the noticing, the understanding, and the prediction of what's going to happen in the future, or being able to mentally prepare for what's going to happen in the future, you can simulate in a very low fidelity room. You need to get a team together, you need to get a checklist, or you need to bring up a scenario, and you can practice and you can repeat that over and over and over again, and you can increase what I call the index of suspicion. Another way of saying situational awareness amongst individuals, what to look out for. Because if people don't know what to look out for, they will never see what passes in front of their eyes. Just to share with you some red flags in teamwork, in a simulated environment or in the real world, there's a number of things that can make you aware that somebody within your team isn't performing. And one of the greatest ones is the one at the bottom there, displacement activity. What that means is somebody starts scratching their head or looking or staring at a wall or something like that, which tells you that their brain is working, but they don't actually understand what's going on. And it's in those moments that you can really start to pick things apart and try and decrease cognitive load within your team members. There are some things called mental models. And again, simulation can really aid in trying to help teams form and share the knowledge they have. And it requires people to understand the knowledge that people within the team have, the experience they have, the expectations they have from each other. Mental models and being able to share mental models so all of the team is on the same page is really important. And most of that comes through communication. And communication is something that aviation does pretty well. We in anesthesia are coming to the conclusion that we need to think about critical language. What does that mean? Well, what that means is that we should minimize the amount of communication we have about anything outside of looking after the patient, especially in high risk times. So at induction, at extubation, at high risk points of the surgery, we should limit the amount of communication going on in the team within theatre to only what is directly related to looking after the patient. And that's something that comes out of aviation, the sterile cockpit methodology or terminology. And again, that's something that you can simulate and use without the use of any high fidelity tools. You just need to practice talking, and that's quite easy to do. There are some factors that increase errors, of course, and they're listed here. I won't go through all of them, but it's quite important as team members, whether you're in simulation or not, to look out for them in your other team workers. And one mnemonic that I quite like is this one. It's called HALT. So if you're hungry, angry, anxious, late or tired, it's very likely that you might make an error. And being able to have that insight that you might be one of these things and you might need to rectify that before you carry on looking after the patient. But more importantly, looking out for it in a team member is very important and something that, again, you can simulate. I just very quickly wanted to touch on briefing and debriefing, because this is a really important part of simulation and a really important part of ensuring patient safety. And briefing, I'm sure in the UK at least, we all have a team brief, and the team brief involves a multidisciplinary team talking to each other about the patients on the list, for example, and we like to talk about strategies. It needs to be done well for it to ensure that nothing is missed out and patients don't suffer as a consequence of it not being done well. But really, when you're simulating something, a scenario, the most important learning, and some research would say the only learning that comes out of it, is at the debrief, because the people who are immersed within the simulation are so stressed from being in that simulation, they don't really understand what's going on until you debrief. So firstly, people who are debriefing should be trained in debriefing, and there are some very good websites that I can give links to that are free in terms of training for debriefing. But it's really important to debrief after simulated scenarios and real scenarios to be able to learn. And the next couple of slides are exactly that. They are a debrief at a slightly higher level, but they tell us a lot about what simulation can bring to safety. And so just for the final part of this talk, I want to talk to you about the Ringerike story. And I know some of my colleagues here have heard this before, but it's so striking, it's worth repeating. So Ringerike is an island in Norway. And on the 22nd of July in 2011, it saw one of the worst terrorist attacks in the world, where a young man opened fire at teenagers that had accumulated there for the summer. And Ringerike is a hospital that was about 15 minutes away from this tragic incident. Now, Ringerike Hospital is not a trauma center. It's not geared up to receive trauma, but the actions of the people that were at Ringerike Hospital, the healthcare staff, meant on that day, all the patients they received survived. And that was a better result for survival than any other hospital in Norway that received casualties on that day. And so the Norwegian government sanctioned an independent inquiry as to why the Ringerike Hospital had performed so well compared to the others. And there is a lesson in that in itself. And again, I'm a bit short of time, but learning from excellence, learning from things that have gone well is so important. It's just as important as learning from mistakes. If something goes well, you should debrief it and find out why it went well.
Umair, I think you're muted. Hi, Umair.
There you go. Can you hear me now?
Yeah, I can hear.
Yeah, fantastic. So as I was saying, so the Ringerike Hospital. So let's have a quick look. Let's have a quick look at why Ringerike Hospital performed the way they did. So they were 15 minutes away from the site of the shooting. As I said, they were a small hospital, 120 beds, 12 ITU beds, 6 theatres. They weren't a major trauma centre. When the government started looking at what it was that Ringerike Hospital did, they found out that because it was a very busy hospital, back in 2003, 8 years prior to the shootings, they had pioneered a monthly trauma team training session. So every month, team members would get together and they would run simulations, mainly because they had a lot of time on their hands, but they would do it professionally, and they would define roles for everyone, and they would make sure that they knew each other well enough to know what each person was capable of and what their best roles were within the team. So when the report came out, they identified a number of elements that could and would make difference on that day. And what the government praised was the preparedness and the training that they kept on doing repeatedly. And in that there are many lessons, but mostly simulation works. Simulation works even better if you can repeat it on a monthly, biannually basis, because it's very clear that people like you and me can become de-skilled quite quickly. And so it's really important to keep on emphasizing the technical and non-technical skills through simulation. And I just want to finish with this quote, again from Professor Tolgwande. He says that success requires making 100 small steps go right. Well, I put it to you that making 100 small steps go right means that you need to practice those steps hundreds of times. And the only environment you can do that in is in simulation, where you know that patient safety will not be jeopardized. And just finally, if you haven't watched Chernobyl movie series, I highly recommend it. There's so many patient safety lessons there. And on BBC Sounds, you can find 13 Minutes to the Moon, which is a podcast about how NASA achieved greatness by going to the moon, and the sort of things they came up against and the lessons they learned in safety in getting to the moon. And I highly recommend it if you have some time. Thank you so much for listening, and I'd be more than happy to answer questions at the end.
Thank you so much, Umair. That was a wonderful talk. You've explained simulation, and you've also touched a lot on the non-technical skills, the issue of debrief, and the Ringerek story. So anybody who has questions to Umair, please direct them to the chat, and we'll get back to them at the end of the talk. So our next panelist is Idris, Dr. Idris Chikophe. He's a consultant anesthesiologist in Kenyatta National Hospital. He did his residency and master's in UON, and has a fellowship in pediatric cardiothoracic anesthesia from Israel. He's also our editor-in-chief of our journal, Kenya Journal of Anesthesia and Critical Care Medicine. And he has major interests in BASIC, which is basic assessment and support in intensive care. He has special interests in cardiopulmonary interactions, data science in anesthesia, and simulation. So Idris, welcome, thank you.
Thank you very much, Dr. Waruingi, for that kind introduction. I hope you can hear me, everybody. I think my talk is to basically explain what our experience here in Kenya is and what we do on a day-to-day basis. Just like the previous speaker, we are doing simulation, but most of the time we don't have like the high-tech equipment. So our experience basically is basic simulation. One, we use, the standardized patient or patient relative to sort of train, let's say, residents or even examine residents during their, examination times. So you find that you could even ask a resident to ask a patient or a relative of a patient who's been coached on, specific, ways of talking. So that's the standardized patient. And they don't cost nothing to, bring them on board. We use task trainers, for example, in vascular access. I have interest in pediatric critical illness. And what has been shown in our setting is that the survival of a critically ill child in our setting is the ability of the first line clinician to, do vascular access. So you find that many pediatric patients actually have poor outcomes just because the training of vascular access is not a standardized thing. So you find maybe in one emergency room, they get the vascular access quickly, but in another emergency room, they don't get it at all. We use low technology like the chicken drumstick to do, intraosseous cannulation to just feel the loss of resistance. We also use intubating mannequins. Of course, the airway management is a complex level kind of a skill. So we still have to do lots of simulation, especially in the critical care setting. You see, in the theater setting, quite a number of the patients come while they've already been evaluated electively, but in the intensive care unit, I think the number of difficult airways is almost 10 times what you find in the operating room. So we have the mannequins that you use to perform intubation and other tasks like maybe self-defibrillation during training for advanced life support. Again, we have tabletop discussions, which basically help us do better teamwork. When I moved to Kenyatta National Hospital, that is the year that we did the separation of the Siamese twins. It's something that the hospital had not performed before, but there were repeated meetings talking about the steps that you're supposed to carry out to make sure that this whole procedure, goes without any, bad outcomes. The whole nation was watching, all the media people wanted to know, the outcome of these Siamese twins. So we had to have meetings. We had to have the chief anesthetist, two chief anesthetists, who their assistants were, the steps from intubation all the way to transport of these two babies after their separation to the intensive care unit. So that was quite a big deal in terms of learning about simulation. Personally, I have lots of interest in mechanical ventilation because it's something that has erupted, especially during these COVID times. You find that places that did not have intensive care units now are running mechanical ventilators. And I think mechanical ventilation has been responsible for more deaths than any other form of treatment, especially during this COVID time. So I actually have a smart lung where I can demonstrate, troubleshooting in terms of where the problem is. Is it in the airway itself or is it in the parenchyma? There's some physiologic concepts I wouldn't understand if I kept on reading the book until I simulated with a virtual simulator. And so all this physiologic modeling can actually be done maybe using a virtual simulator, which is a high fidelity simulator. And it doesn't cost a lot of money. Most of them are basically open source, or maybe they cost like maybe $5 a month to sort of do the simulation exercise. But does it have to be like high fidelity, low fidelity? Does it have to be high technology or low technology? I think the goal of your simulation, what you want to pass across, the message that you want to pass across is more important than the technology, just like the previous presenter said, right? So if you just need to communicate, like I think there was a time I was talking to a junior anesthetist to just prepare atropine because the patient looked like they would need atropine at some point, but instead of preparing the atropine, they prepared and administered. So basically the communication there was a problem. I probably wasn't good at communicating, or probably he didn't get it. So I think communication is one of the things. In fact, more than 30% of sentinel events that happen are due to poor communication, and communication could actually be rehearsed over and over to just get matters right. So I don't have much to say, but I think at the end of the day, you need both psychological equipment and environmental fidelity in whatever you do. Like airway management is a high adrenaline kind of a situation. So when you're doing your simulation, you try as much as possible to mimic the level of difficulty, to mimic the stress that you experience when you're doing an actual intubation. You need the equipment fidelity so that if this airway is difficult, you have to have the McCoy, you have to have the video laryngoscope, and if possible, let's get the fiber optic. And environmental fidelity is whereby if the patient has a difficult airway, then they should desaturate, and you should hear that tone of the pulse oximeter going down the way it would in a normal situation. Thank you very much, Dr. Waruingi, for the opportunity.
Thank you, Idris. That was a very, very excellent presentation. At least you built up from what Umair had started out on. Umair touched on high fidelity simulation and touched on non-technical skills and how we can integrate both of that with traditional teaching methods to achieve the same goal. You also spoke about how you've used simulation in pediatrics, and you touched about the Siamese twins and how teamwork was an important component in that. Thank you so much, Idris. So next will be Dr. Odaba, and any questions to Idris, please direct them to the chat, and we'll get back to you at the end. Next is Dr. Odaba, who I've had the privilege to work with. He's been my mentor and also a senior colleague. We share the same names. He's a consultant in Anaesthesia and program director in Aga Khan University. So he's involved in training in an institution where I did my residency. He has a special interest in medical education and simulation, and he'll talk about simulation, and let me just allow him to have the floor. Thank you, David. Welcome.
Thank you, Dr. Waruingi, my namesake. My apologies, I joined in late. I had certain engagements that went beyond the estimated time of completion, but it is our life, so we have to live with it. So I might repeat some of the things that my colleagues have already spoken about, but I will give my experience, both during my training and as a trainer as well, how we are trying to integrate simulation. And I think for me, I look at simulation in the sense that it's that aspect of training that we don't think about, things that we rarely encounter, and you will meet it once in a while, maybe during your career. And so the skills that you gain in some of those simulators would actually be quite useful. I think for our training, and we recently reviewed our curriculum, and it's quite heavy on simulation, simply because we realized that we can't possibly cover everything that we need to cover in the 4-year period if we were to just rely on the patients that we meet. And in any case, some of those cases, when you meet them, it's not a safe environment, because you can imagine trying to teach someone a skill using a live patient in real time, and they are not supposed to make any mistakes. And we all know that at some point we have to make mistakes for us to learn from them. So I think simulation comes in handy. We use simulation to cover both technical and non-technical skills. And so most of the time you find that for the technical skills, we use task trainers, and we have quite a number of them. And I think Dr. Chikophe has alluded to some of them, whether it is for CVC, we have a task trainer for lumbar epidurals, we have task trainers for arterial line insertion, and a few others for intubation and such. And then we have low fidelity mannequins, like the ones we used to train residents on just CPR, the usual advanced life support. But we also have high fidelity mannequins, and those you can literally train residents on very many different aspects of anesthesia. So for example, one of the mannequins, the high fidelity ones, we can use it to imitate anesthesia crisis in theater. You can imitate bronchospasms, you can imitate arrhythmias, you can imitate severe hypotension, and many other things that you can actually do, including chest tube insertions. So those we use for high fidelity simulation. We don't have a simulation center yet, at least not in our Nairobi campus. But we are lucky that our sister university has an accredited simulation center, albeit very far away. And it's actually recently got accredited by the Simulation Society, Society for Simulation in Healthcare. So it's quite a fairly advanced simulation center. And what we've been doing is we've been capacity building for our local faculty. So we send the faculty there to train as trainers in simulation, because it's one thing having the simulation center or having the mannequins, whether low fidelity, medium fidelity, or high fidelity, but it's quite something else trying to design a simulation course that is mapped to a certain competence in the curriculum. So what we've had to do is we've had to break down the curriculum into the different competencies and then map those competencies to the most likely source of attaining those competencies. So if it's an non-technical skill, yes, you'll pick up the skills in theater or other clinical areas, but then we are also hoping that we can actually simulate some of those scenarios in a safe environment where our trainees can actually learn safely how to model some of that behavior. Things like crisis resource management, for example, in anesthesia, it's a big thing because we are always managing crisis. But how do we deal with those crises in a very complex environment like a hospital? It will be, I think it would be unreasonable to expect that just by going to theater or going to the wards or going to the clinic or the sedation areas, that somehow the residents will pick up some of those competencies. So what we've actually been trying to do is incorporate that in the training and then specifically design simulation courses or sessions so that the residents can actually pick up those competencies. How well have we done? Well, not quite well. We are still in our infancy. So actually at the moment, we are still capacity building. We've engaged some of the international simulation centers to try to help us capacity build, have our faculty trained, and then hopefully very soon we are going to have our very own simulation center that will have the whole range from task trainers to medium fidelity simulators, all the way to the high fidelity simulators. And then we should be able now to take off completely and run some of these courses on our own. I think we have tried to compare with the international bodies in terms of training. And I think, for example, in the UK, a good medical practice or the good anesthetists from the Royal College of Anesthetists, and more so, for example, in North America, the Canadian Physician Competency Framework. So if you look at those policies or those documents, there's a lot of emphasis on non-technical skills. So if we take, for example, the CanMed framework, being a medical expert is only one out of possibly 7 competencies that you are expected to acquire during your training by the time you become a consultant. Now, some of those things might be quite difficult to gain by just apprenticeship, going to theater, going to the wards. So it's those aspects of training that we feel might not come out clearly during everyday training that we are trying to incorporate into simulation, and hopefully that should get us somewhere. I mean, it's a no-brainer that, for example, the pilots, when they are training, of course, they don't train how to manage a crashing airplane.
Odaba, I think there's a problem with your voice. KSA admin, please assist.
Aeroplane, inside the aeroplane when it's...
Sorry, Dr. Odaba, I think we missed a bit.
Can you hear me now?
Yeah, we can.
Okay, you can hear me now?
Can hear you.
Yes, you can continue.
All right, okay, thank you. My apologies. So I was just saying that our aim is actually to try and simulate some of those non-technical skills which are core to our functioning as consultants out there, but which we might not, our residents might not be exposed to in a safe environment. And I was giving an example of pilot training, for example, and I think airlines were way ahead of healthcare, even though I think a hospital is a more complex environment than an aeroplane, or a Boeing 747, for example, just by virtue of the sheer number of different professionals you have to interact with. And we all know human beings are very complex creatures. So dealing with 50, 100 different cadres of staff is a lot more complex than dealing with a machine. So it's a pity that we are playing catch up in healthcare when we should be actually pioneering simulation. So the whole idea is that we get our trainees in a safe environment where it's fine, even if they manage the crisis poorly, at least they'll use that as a learning point, and they'll get feedback both from faculty and from fellow trainees who are watching how they're observing, how they are performing. And like Idris said, some of these simulations that don't need a lot of resources. We have scenarios where, for example, in professional development, we train the common courses where the residents are actually taken through different aspects of professionalism using actors. These are professional actors who can imitate any scenario, and that you don't need a lot of resources for that. So we've been doing that as well, as a supplement to our main training. So I think that is where we are at. We are skewing our training heavily towards simulation, especially for the non-technical skills. The technical skills, we still have the task trainers and the wet labs, but then some of those we can at least get in the theaters. I think I will stop there. My 10 minutes are up.
Thank you, Odaba.
Thank you.
Thank you. So, thank you very much, Odaba. I like that you've highlighted about task training, and you've spoken about how you're building capacity as an institution and training more and more of your faculty to help incorporate this into the curriculum. That's very good. So anybody with questions to Dr. Odaba, Idris, and Umair, please direct them to the chat. And without further ado, I'll introduce our final panelist for today, which is Dr. Carl Hillermann, who I've also worked with before. So Carl Hillermann is, he was initially born in South Africa, and he qualified in the University of Pretoria. And then he did anesthetic training there, and then further moved, then went to the UK. And he has a special interest in regional anesthesia, pain medicine. He's also a Royal College of Anesthesia examiner and vice chairman of the primary FRCA MCQ exam. He's a clinical lead and one of the clinical directors in university hospitals, Coventry and Warwickshire. He's also a simulation lead for the high fidelity sim lab that they have in Coventry. So welcome, Carl.
Thank you. Thank you for the introduction and the invitation, David. The previous speakers have sort of given us a lot of information, and I just thought I'd bring some salient points from those, because simulation and the education of non-technical skills is very close to my heart. So I'm very pleased to hear from your namesake, David Odaba, about the moves to embed it into the curriculum and to embed simulation into the curriculum. Because from my perspective is that it's the language of that we try and bring across in simulation of non-technical skills like situational awareness, communication, leadership, etc. All of those, they need to become as important as learning about airway skills and so on in our curriculum and in our day-to-day working. And in that way, we can start embedding things that are so important into our day-to-day life. And it's very encouraging that they're doing all of that. And I think the other important thing is to try and bring simulation into the workplace, so it isn't an alien concept anymore. And these are very important principles that we need to encourage. And there it is different to the airline industry, because we can't, all our patients are different, our environments are different, our teams are different all the time. And it's the engagement with all the members of the team that is important to get this culture into our hospitals. There's a few educational principles that are also important. And as has been alluded to by both David in the last talk and by Umair, the debrief forms the most important part, in my view, of simulation. And it's where most of the learning occurs. And it's very important to get that debrief right. And the key from my perspective is that in that debrief, and there's a number of ways you can debrief, there's a number of models, the key is in all of these is the non-judgmental way in that we perform those debriefs. It's very important, because in a non-confrontational, non-judgmental way, that everybody has good take-home messages and learns from this. And a simulation experience isn't a one-off experience. It has to occur multiple times for you to develop those non-technical skills. And I think people are very focused on the fidelity of the simulation. And I'm not saying that fidelity isn't important. Fidelity does have some importance to it, but it's also the environment. So you can bring your Resus Annie, where you do CPR training, you can use that in a theatre situation with the right sort of learning outcomes which you have before. You can bring that into a theatre environment and do excellent simulations there. If the environment is right, then your simulator becomes less and less important. And Umair mentioned the Norway experience, and I was lucky enough to visit Guthrum Bretto in Norway, and this was back in 2004, and they started simulation training for trauma teams in their network, and they would just bring their Resus Annie along and team, but it was all about the team training, and there's some quite good evidence about how that improved teams which were sort of low functioning teams, how it brought them to become high functioning teams. And they did that on quite a small budget. And so that is sort of the key message from my perspective. The difficulty we have, and we have it here, even though we've got a nice simulation lab and so on, is engagement and culture. And you have to develop a culture for non-technical skills. And you start that, I think, by embedding it into, even before they become anesthetic trainees, embedding it into the curriculum at medical school and so on, that it becomes a culture of people knowing what situational awareness is, knowing what the risks are, etc. And in that way, we can move forward and reducing, one of Umair's first slides, medicine from a dangerous, high-risk environment, moving it more towards a low-risk environment for our patients. And I think that's what we're there for. And I think that's probably time. I'll hand you over to David.
Thank you, Carl. Thanks, Carl, for that enlightening conversation. You've reiterated what all the previous panelists have said, and we really appreciate your insights. You've spoken about simulation, and it doesn't matter whether it's high fidelity or low fidelity, just as long as you just get it going. You've also highlighted about the non-technical skills, the issue of teamwork, and the concept of debrief. And maybe we need to inculcate all this to ultimately promote patient safety. So thanks a lot for that, Carl. So anybody who has questions to any of our four panelists, please direct them to the chat. And for now, we'll just have, as I'm going through the questions, I'll allow the sponsor to just speak briefly, then we can have a Q&A session. Thank you.
Just to begin with, it's good to mention that Sanofi is a company that's been authorized to manufacture and also market Epilim, which is a sodium valproate, indicated for epilepsy. And epilepsy, as you are aware, is a condition that has really posed a big burden worldwide. And I want to believe that in your day-to-day work, there may be a need for an AED. And it's my pleasure to take us through. If you allow me, I can share my screen. To take us through Epilim. And it is very important to mention that it's the responsibility of Sanofi to communicate this very important information, that valproate should not be prescribed to female patients and women of childbearing age unless other treatments are ineffective or not tolerated. To mention also, Epilim has stood a test of time. Over years, Epilim has kept a constant proof of efficacy, regardless of seizure type or etiology. And looking at recommendations, NICE Guidelines 2012 recommended Epilim for first-line treatment, regardless of seizure type. And looking at a study that was done in 2007, SANA study, it was done to compare long-term effect of valproate, lamotrigine, and topiramate in patients with generalized onset seizures. And the primary endpoint was to compare time from randomization to treatment failure and to a 10-year period of remission of seizures. And according to this study, standard study, it came out to clearly note that epilim has a better outcome on the primary endpoint. To mention again, in addition to wide spectrum of efficacy, epilim has a better safety profile. For your convenience, we have various formulations. We have tablets for adult cases. We have suspension or syrup for the pediatric cases. And for our department, ICU, we have IV for emergency situations. So the recommended dose for adults, it is recommended a loading dose of 400 to 800 milligrams and a continuous infusion up to a maximum of 2,500 milligrams per day as a maintenance dose. For pediatrics, it is recommended you do a loaded dose of 20 to 30 milligrams per kg. It is also very important to note that you may need to replace epilim IV with oral epilim as soon as it is practicable. To mention, in addition to what I've mentioned earlier, epilim IV is well tolerated and can be used as an effective AED in no-seizure emergency situations. As I conclude, it is very important also to mention where epilim IV is available. Epilim IV is available in private hospitals, in public hospitals, in KEMSA, which takes care of our county hospitals, in MEDS, that also takes care of our county hospitals and mission hospitals. And at this juncture, I want to say thank you for listening to me, and back to you, Dr. Waruingi. Thank you.
Thanks, Catherine, for that sponsor message about epilim. I'm sure most anesthetists have used it at some point in their neurosurgical rotations. So we'll get back to anybody who has a question. I've been seeing Umair has been responding on chat to everybody who's been asking questions. But before then, there's no further question. I'll appreciate all of you for coming to this webinar. I also appreciate all the panelists for their enlightening talks. And I'll just have a brief take-home message from each one of them as to what we need to remember about simulation and patient safety. So I'll start with you, Umair.
Well, firstly, thank you so much, David, for arranging this, and thank you everyone for listening. My only message will be, you don't need a high fidelity center or even a simulation center to be able to rehearse the processes and systems that you are going through every day on a daily basis. I will encourage all of you, as I've been saying on the chat, to start somewhere. Everybody has to start somewhere. You just need a room, you need a team, and you need a scenario, or you need some kind of process that you do, and you just rehearse it over and over again to perfect that non-technical skills, the communication, the team working, to get to know each other better, because we know that when we know each other better, we perform better. Thank you so much.
Thanks so much, Umair, for that. Idris, any take-home message?
Can you see me? All right, so thank you very much for this opportunity again. Really, everything has been said. I don't want to repeat myself, but let's start now. Those who have not started, let's do it straight away. Thank you.
Let's start. That's from Idris. Take-home message, Odaba.
Thank you, Dr. Waruingi, and thank you everyone for taking your time to come and attend the webinar. I think I don't want to belabor the point that my colleagues have put forward, and I think for me it's just being able to give an anesthetic is not enough. I think for me that's the take-home message, that it takes a lot more than just being able to give a GA or being able to give that regional anesthetic to be a really good anesthetist. And I think whether in a university hospital or not, we are all teachers. And simulation in one way or another is going to be useful wherever it is we are working. And we need to go beyond being able to give an anesthetic to achieve our full potential. And simulation is one of those things that will help us actually practice those non-technical skills, non-being anesthetist things that are going to make all of us great physicians. Thank you.
Thank you so much, Odaba. Take-home messages. Al. Dr. Hillermann.
Yeah, hi, yeah. I think I agree. I just want to reiterate what Umair says. I think, you know, you can use it, you can start anywhere. I think the main thing is start talking about non-technical skills and start talking to everybody about non-technical skills. Start young medical school and so on, but in your base hospitals, just even if you start debriefing clinical situations, that you start thinking about communication, thinking about leadership and so on. I think that's a good start already, and then you can build from there.
Thanks, Dr. Hillermann. I think without further ado, I just want to thank all of you for this really, really enlightening presentation. I've also learned a lot. My take-home message is just let's start the non-technical skills debrief. And I want to invite you all for another webinar. And I'll also appreciate our sponsors for this. And I appreciate all of you busy people for taking time to come here. So thank you and good night.